Now we have up to now, if this was the pelvis, we've covered the borders of the pelvis, all the borders of the pelvis. We began with the pubic symphysis, went to ASIS, across the iliac crest, then the greater and the lesser sciatic notches, ischial tuberosity, ischiopubic ramus, and we came back to the pubic symphysis. We covered the bone and we covered its attachments. Then we went inside the pelvis, looking from inside, and we suspended the pelvis from the abdomen by the three muscles: transversus abdominis, internal oblique, external oblique, then the iliacus, the psoas, the artery, vein and nerve, then the obturator internus, and then we placed the levator ani, which is the diaphragm, horizontal muscle, which divides the inner cavity into pelvis above and perineum below, and this perineum passed the urethra and vagina directed anteriorly, and that triangle was called the urogenital triangle, and then it passed the anus backwards, that was called as the anal triangle. Now we start seeing the outer surface of the pelvis and attaching the lower limb to the pelvis. Now, the first thing that we are going to study here will be the hip. So we are beginning from inside outside, inside to outside, and first of all we'll stay intracapsular in the hip. Hip has the acetabulum articulating with the head of the femur. The acetabulum is a pincer-shaped cavity, and this is the articular cartilage or the articular portion, and this one here is the non-articular portion. The tips of the pincer are connected by a ligament which is called as the transverse acetabular ligament. Then the ligamentum teres, this one here, arises from the ends of the notch and the transverse acetabular ligament, and it goes upwards and attaches to the fovea capitis of the head of the femur. The obturator foramen will be somewhere here. This is the six-shaped obturator foramen from which emerges the obturator artery, this one. This is the obturator artery, and this gives artery of ligamentum teres, this one, and that enters the acetabular notch medial to the transverse acetabular ligament, rides on the ligamentum teres, enters the head and supplies 3% of it. So this is what we have said, and this cavity is increased by a cartilaginous labrum at the margin, which sort of provides some sort of a resilience also, but basically it increases the depth of the cavity. Now, we have said about the labrum, we have talked about the transverse acetabular ligament. We have said that arising from the ends of the acetabular notch is the ligamentum teres, and how it goes and gets attached to the fovea capitis. So here is what you see. This is the transverse acetabular ligament, and this is the ligamentum teres going and getting attached to the fovea capitis and supplying 3% of the head. The obturator artery gives the artery of ligamentum teres, and that enters the acetabular notch. You see, The notch is somewhere behind the transverse acetabular ligament. It enters here, rides over the ligamentum teres and supplies the fovea capitis. Now you notice that the artery of the ligamentum teres, and we have seen how it passes into the head, supplying 3% of it. The other supply of the head starts from, so this is the femoral artery, and the femoral artery and the profunda femoris, its branch profunda femoris, they sort of forceps the adductor longus muscle, and this profunda femoris embraces the subtrochanteric region of the femur, giving by its two branches, the medial and the lateral circumflex femoral. The medial and the lateral circumflex femoral. So you see this arch, it is sort of profunda femoris embracing the subtrochanteric region by the medial, this one is the medial and the lateral circumflex femoral, and this arch makes another arch on the base of the neck by the ascending branches of the lateral and the medial circumflex femoral. From this arterial arch arise the retinacular vessels or lateral epiphyseal vessels, which pass anterior and posterior to the neck to supply the rest of the head of the femur. So these are the retinacular vessels, and we'll see the anatomy of these retinacular vessels in a little bit greater detail. So here is the neck of femur. Around the neck of femur, if this is the head and here is the capsule and the synovium is going like this and reflecting on the capsule, this is the synovial cavity. Therefore, there will be two layers of the synovium, the visceral and the parietal layer. So, when these blood vessels are passing near the neck, they will raise a fold in the visceral synovium, and that's why they are called as the retinacular vessels. Now, these retinacular vessels will cross the growth plate. This is the growth plate. These retinacular vessels, being extra osseous outside the bone, will cross the growth plate and supply 97% of the head. Whereas the nutrient artery, which is intraosseous, will be stopped by the growth plate. So the head is dependent 97% on these retinacular vessels. There are the anterior and the posterior ones, and only 3% of it is dependent on the artery of the ligamentum teres. Now what happens that if there is increase in pressure here, these retinacular vessels will get compressed. So will the artery of ligamentum teres, and the head will become avascular, at least for the time being, till there is increase in pressure in the synovial cavity. This is called as the tamponade effect. So, after this, what will happen? That the ossific nucleus would stop growing. So this ossific nucleus on this side will become much smaller than the ossific nucleus on the other side. Then it will become more radiodense. That means it will become sclerosed, shrunken, and it may fragment. So it may fragment. We'll show it to you by this color. So it may actually fragment. We intend to show the fragmentation by the black color. So it will fragment like this. And then it will soften. So it will become sclerosed, it will become shrunken, it will become fragmented, and it will become soft. Then, if it is soft, then this nucleus may go down, it will become flattened like this, and if you see it from the superior view, it may go back. So if it goes down, there will be an adduction deformity, and if it goes back, there will be an external rotation deformity. So the basic thing that is happening is that when it becomes soft, it becomes disshaping, and if it goes down, there is an adduction deformity. If it goes back, there is external rotation deformity, and if it becomes flat, so it has become flat, and the acetabulum is round. So this is called as loss of sphericity. Then, since it has become flat and the acetabulum is round, it has become less spherical from the acetabulum. Therefore, its distance from the acetabulum is now not same. That means there is incongruity. It is called as incongruity. And finally, it goes outside the rim of the acetabulum, and this portion outside the rim of the acetabulum is called as chylus, and this is called as lack of containment. It is not contained. So the effects of softening are adduction deformity, external rotation deformity, loss of sphericity, lack of congruence, and containment. Finally, this acetabular rim dents the head wherever it is touching it. And now, instead of the abduction occurring on the axis of the head, it starts occurring at this place, and abduction is decreased. So this is called as hinged abduction. So I told you, goes back, external rotation. Goes down, adduction deformity. Sphericity is flattened, and therefore I told you this is the chylus. There is incongruence, and there is lack of containment, and there is hinged abduction. I have told you all this. So the idea is that we must recognize Perthes disease as soon as possible if there is pain and limp in a 5 to 10-year-old child. Basically, one important physical sign is the roll test where internal rotation will become painful. Now you treat the synovial effusion. The thing is, you may aspirate, subject it to TrueNet, etc., to rule out tuberculosis and treat the effusion or decompress the effusion. The second thing is, you may be asked how you study the circulation of the head. It can be by the radio scan, the PET scan, or contrast MRI. The radio scan is by Technetium 95 uptake. Then you must restore the circulation. Easy thing is, you may put the child on Disperi. Then you maintain bed rest and traction and till the acute stage subsides. You recognize subsidence of acute stage by absence of pain on trying to internally rotate the head. Then you ensure containment. Now this containment is by, till the child cannot walk. It can be by a Pollock harness or a Von Rosen splint. But when the child walks, there is this tricycle brace where the weight is being transmitted on this pylon and the limb is being held in abduction, internal rotation by this extension. So this is the tricycle brace. And you have to continue till the head of the shape is normal. So how does it become normal? So first you see that this is the ossific head. Then you see new bone formation around the head, which is called as the head in head sign. This is the reactive new bone formation. And finally the head reaches its normal shape, but sometimes there is loss of the lateral side, and which is called as lateral pillar loss. So this is called as the gauge sign, and it indicates a head at risk of deformation. So supposing all this has happened and the head is deformed, so you assess the functional problem. Because of adduction deformity, there can be a Trendelenburg gait, and because of the external rotation, the patient may be walking with foot in external rotation. Thirdly, there may be hinged abduction. That means flexion is restricted in neutral position, but as soon as you abduct, flexion becomes full. Finally, you assess the radiology. You look for sphericity by Moses circle, congruence and containment. And if containment is unacceptable, then you remove the callus, and you improve the containment either by a pelvic osteotomy or by a femoral osteotomy. Now, pelvic osteotomy is for the acetabulum, and femoral osteotomy aligns the head. There is a subtrochanteric femoral osteotomy that aligns the head in neutral position of the limb. Okay? So the pelvic osteotomy is better because it has a lesser convalescent period. You don't have, the child doesn't become bedridden for a long time. Now the osteotomy can be Salter or Chiari, where it's a full osteotomy from the greater sciatic notch to the I'll show you how it is. This is the iliac crest, the anterossopiliac spine, anterossopiliac spine, pectineal eminence, notch far trivenian nerve, pubic tubercle, pubic symphysis, istiopubic ramus, lesser sciatic notch, ischial spine, greater sciatic notch, posterior iliac spine, posterior subiliac spine. Here is the acetabulum. Okay, and here is the obturator foramen. So now most osteotomies are from greater sciatic notch to above the pectineal eminence. Now if you open this osteotomy, anteriorly, this lower part of the pelvis will move downwards. It will become downward directed. That means the tilt will increase, and this is called as Salters. Secondly, if you do an osteotomy like this and you displace the upper part laterally, then it will improve the containment of the acetabulum. Now that is called as Chiari. The third thing is that you can simply do a osteotomy above the acetabulum and open the wedge laterally, so that the roof of the acetabulum becomes more horizontal. Now that is called as Pemberton. And finally, you can detach the acetabulum from the ilium, from the ischium, from the pubis, and align it in the manner that there will be more coverage of the head posteriorly and superiorly. That is called as dial. Now, an important thing is that if there is hinged abduction, you have to remove the callus so that the abduction is restored. In very late cases, if there is a lot of severe pain and it's disabling because of the secondary osteoarthritis, then you do a total hip replacement. So this is the hip and Perthes disease and intracapsular attachment of the pelvis to the lower limb.